March 20, we have a successful campaign of membership campaign where you have a very depreciation in the membership fee. So also the state president and state secretary is taking up a huge task of visiting all the branches. They have the Sandesha Yatra, and that will happen in the 2nd or 3rd week of March in Thrissur district. We are planning to have 2 or 3 days in the district, visiting all the 12 branches. This is for membership campaign to enroll more and more members. As we can see that even though the number of registrants in TC Medical Council is around 80,000, we have only 30,000 members in Indian Medical Association Kerala State Branch. Of course, there may be a few who have already been expired and shifted to other places, but then there is a huge gap of many members not joining in Indian Medical Association. So this year, our aim is to achieve the 50,000 mark of membership in Indian Medical Association. So for that purpose, the state president and state secretary has taken up this massive campaign of visiting all the branches, motivating people to join. So my request to all of you is to cooperate and find out your friends who are not members of Indian Medical Association, ask them to join. So also we have the various schemes of social security schemes or professional protection schemes and join. So with this words, wishing all the very best to the CME. I conclude. Thank you. Jai Hind, Jai.
Thank you, Dr. Gobi Kumar, for your address. Now, the scientific session. Now I invite our Secretary, Dr. Joseph George, to introduce Chairperson Dr. P.C. Gilwas and invite him for the session. Over to you, Dr. Joseph George, our Secretary.
Dr. P.C. Gilwas, MD, DM, HOD, Department of Neurology and Medical Superintendent of Jubilee Mission Medical College, Thrissur. Sir did MBBS and MD from Madurai Medical College, Madurai, and joined Jubilee Mission Medical College, Thrissur as physician in 1982-83. Then he did DM from Chennai Medical College and joined Elite Mission Hospital, Thrissur as the first neurologist of Thrissur. Later joined Jubilee Mission Medical College, Thrissur, started neurology department and now HOD of Department of Neurology and Medical Superintendent. I invite Dr. P.C. Gilwas on today's one of the chairperson to introduce Dr. Sajeev Thomas and to invite him for the talk. Thank you. Over to you, sir. Dr. Gilwas, sir.
Thank you, Dr. Joseph George. Eminent members of the IMA, it is such a pleasure to be here once again. And it was such a pleasant task to introduce our speaker, the first speaker, Professor Sanjeev Thomas. Professor Sanjeev Thomas has been on the neurological ferment for as long as I can remember. A very silent worker who has made his mark at all levels of neurology, especially in epilepsy. He has been Fulbright professor at the Ohio State University, Columbus in 2011. Importantly, he has been an ambassador for the ILAE for epilepsy. And these are just a few. To go on, he has been on the task force for women with epilepsy. He's been on the task force for treatment guidelines with epilepsy, member of the AAN guideline committee. He's also been the past president of the Indian Academy of Neurology, the editor of the Annals of the Indian Academy of Neurology, innumerable papers, innumerable chapters. it is a great pleasure, a great honor to invite Professor Sanjeev Thomas to this meeting. And the topic has been so well chosen, so apt for Dr. Sanjeev. Epilepsy beyond seizures, because really epilepsy is beyond seizures. It's not just about the treatment of a condition. It is so much more beyond the seizures. It is the intricate planning, the intricate thought process which goes into each and every patient, the planning of their marriage, of their pregnancy, a whole lot of things which goes beyond the seizures. So to speak on this topic, I have great pleasure to invite Professor Sanjeev Thomas onto the dais. Over to you, Sanjeev.
Thank you, Dr. Gilvas, for the kind words. I hope I am all well audible.
Yes.
Thank you. It's a great pleasure to join the IMA Thrissur in the CME program and meet many of you online. And I am happy that I can share some of the thoughts that are important from the epilepsy viewpoint. More than that, this is also an opportunity for me to go back in my memory into my initial career when we had walked on the streets of the joint areas of Thrissur, Palakkad, and the Malappuram to carry out a survey of the epilepsy in Kerala state. So that is also another reason. I had earlier come to Thrissur to give a talk that was probably 91, 92 when Professor Mohan had asked me to come there and give a talk. So there are fond memories. Some of my close friends like Dr. Gilvas and Professor Dr. Ajit, they are all in Thrissur. So good to be back with all of you. And I would like to now share my screen and go to my talk. I suppose my screen is visible to all of you.
Yes, yes.
Yeah, it's clear.
Yeah. Right now, by the way, I have left Sri Chitra Tirunal Institute. I have retired from there and joined the Institute for Communication and Cognitive Neurosciences in Shornur and Thrissur as full-time director. Why is this not going down? Yeah. You know, this year, the International League Against Epilepsy and IBE Bureau have taken a new topic for the International Epilepsy Day, and that is epilepsy is more than seizures. And today I am not going to talk anything on pharmacotherapy or specifically about women with epilepsy. If there are questions related to that, I can take it at the end of the meeting. But I thought certain other areas which we don't often discuss may be interesting to discuss here. So this was the survey that I was referring to, and at the Dr. Radhakrishnan sir had actually pioneered this survey, and we found out that about 5 people per 1,000 in Kerala have epilepsy. This is the situation. This was the situation in 1994, 95, that period. Now let me familiarize you with the new classification of seizures and epilepsy. Interestingly, the people in epilepsy have been always very much enjoying classifying, reclassifying, again classifying, later going on for centuries, I think, together. So right now, a new classification has come, and this is probably what is going to stay for another 10 or 20 years. This classification is designed to enable a physician to classify epilepsy at a primary care center without much investigation, or at an advanced center with all the facilities, genetic studies, MRI, everything. So it is quite flexible in its design. That is the beauty of this classification. It also is a classification which accommodates information as it comes. I will explain that and familiarize with you with it. Basically, seizures are divided into focal seizures, generalized seizures, and unknown onset seizures. These unknown onset seizures are an important category because earlier that was not there. If we do not have a good history, we do not know whether this was a focal seizure which has turned out finally generalized or not. So if the onset is not clear, we can put them in the unknown onset category. So that's why I said it is flexible and it can accommodate information as it comes. Focal onset seizures, as we know, starts in a focal part of the body and spreads to other parts, or it may not spread. And it may be with the impaired awareness or with preserved awareness. The old term was, partial complex seizure or complex partial seizure. People felt that these words do not convey anything by itself. You have to read what does it mean. Whereas if we say that, focal seizures with impaired awareness, it is self-explanatory. There is no need to go on explaining that. Focal seizures with preserved awareness is similarly, it is easy to understand. So we have this new classification has done away with the complex partial seizure, simple partial seizure, that terminologies. Then the generalized tonic-clonic seizures, if they are generalized in onset only, they will be called generalized onset. If they are focal, it will be differently classified. It will be classified as focal to bilateral tonic-clonic seizures. So if there is a focal onset and what we earlier used to call secondary generalization and all, now the term should be focal to bilateral tonic-clonic seizures. And the unknown I have already said. And there is also further scope for expansion of it. Motor seizures can be further classified. I am not going into the details of that. So this is the new classification of seizures which has come. The ILA has approved it in 2017, and all the publications and other things that go to epilepsy should follow this classification according to the new definitions. We all know that seizures does not mean exactly epilepsy. A tendency to get recurrent seizures without a provocation is what epilepsy is. So epilepsy classification is slightly different from the classification of seizures. Here, the first step in the classification of epilepsy is to classify the seizures. That we already did, focal or generalized and unknown. The next step is to find out what is the details about it and the etiology for that. Is there a structural pathology for which we may need to do a physical examination supported by imaging? If that is normal, sometimes or in some situations we'll have to do genetic studies. If there is an infectious etiology suspected, we have to go after that, metabolic, immune, and several other etiologies are there. So this class, if we stick to this classification, it helps us to order our investigations in a logical and economical way. That is one advantage of it. Okay, I have made this classification of generalized epilepsy. What are the investigations I should do? If I look at this etiology, what are the etiologies that I need to exclude or include? I can include all these tests depending on what is available. And based on this, finally, we come across what we have an epilepsy syndromes, which are more refined and wholesome epilepsy conditions. Simultaneously, very important is the comorbidities. Until now, comorbidities were not part of the epilepsy classification. So the epilepsy classification form, new classification has given a lot of emphasis for the comorbidities. I will be talking about the comorbidities and epilepsy in this session of this. That is what epilepsy beyond seizures, what I mean. So this is the core classification. This is all about epilepsy. If we have some idea about this classification, sticks to our mind, we can manage our patients in a logical and comprehensive manner. Now, when we as neurologists, there are some issues. Generalized epilepsies. There is a term called genetic generalized epilepsies in this new classification, because what they have felt is that idiopathic epilepsies have mostly a genetic background, and so they should be renamed as genetic generalized epilepsies. Even when we have not seen a specific genetic abnormality to account for that. So this is a debatable issue and it is still under debate. Under that, there are some idiopathic conditions at the moment, what we call idiopathic epilepsies, which are childhood epilepsies, juvenile myoclonic epilepsies, juvenile absence, and generalized tonic-clonic seizures without myoclonus. So these four. In the adults, it is the generalized tonic-clonic seizures without myoclonus. In the adolescent, it is juvenile myoclonic epilepsy and juvenile absence. And in children, it is the traditional petit mal, which now we call juvenile childhood absence epilepsy. So these four conditions are now called idiopathic generalized epilepsies, which now fall under the genetic generalized epilepsies. But genetic generalized epilepsies may have much wider thing. A variety of conditions may be there, which may be mostly seen in children, which may be associated with epileptic encephalopathies, developmental encephalopathies, metabolic disorders, genetic disorders, and so on. I'm not going to go into the details of that. I just mentioned about the idiopathic epilepsy because this is something which every day we see. Juvenile myoclonic epilepsy, where do we say, is it an idiopathic epilepsy or is it a genetic generalized epilepsy? Yes, it is both. It is a type of genetic generalized epilepsy coming under idiopathic generalized epilepsy. One of the four conditions that come under the idiopathic generalized epilepsies. Now, another breakthrough that has come, in which our colleague and friend Dr. Vinayan from Cochin had participated in a remarkable way, is finding the nuances of the neonatal seizures. We know that neonatal seizures have hypoxic etiology to a large extent, vascular, brain malformations, genetic, metabolic, infectious, so many other factors are there. Now, how do we put this in this old framework? So this is how, what is a neonatal epilepsy classification in the broad epilepsy framework that I had earlier shown. You have the epilepsy seizure classification and an epilepsy syndrome. And here on the etiology side, we have hypoxic ischemic as a specific entity. Thereafter, the rest of it is all the other ones. So in the neonatal one, they have put hypoxic ischemic as a separate because of the magnitude of it. Further, if you will look at it, there is a subtype of seizure called electrographic seizures, which was not there earlier. So today we know with the continuous EEG monitoring that newborns may have subtle seizures which may not be clinically manifest. Maybe the only changes may be EEG changes, and this may have a bad outcome. So, and identifying it and treating it becomes very important. So that is why these electrographic seizures have been brought in. Similarly, finally, the comorbidities condition also come there. For the newborns, so they have put an algorithm in which This is a paper I was referring to, in which Dr. Vinayan is also a co-author, and this is a pride for our country that he had been in this task force. So we have basically the seizures and electrographic seizures and the type of classification, all essentially the same pattern I was telling. This is an example of an electrographic seizure recorded, and to show that this may be the only finding in these patients. Now let me finish this classification business for time being and look at another aspect, which was earlier rather neglected, the comorbidities part of it. This is again a part in which Dr. Vinayan had been participating very actively when he was in Sri Chitra, looking at the cognitive deficits in children with epilepsy and how does it influence their educational outcome. We know that infantile spasm, Lennox-Gastaut syndrome, children will have severe retardation and they may not make it. But we have a lot of benign conditions like childhood epilepsies which remit after 10, 15 years of age. They apparently we don't have any problems. Do they really have any problems? Is there any risk? So this is one aspect which we need to look at. So we looked at it, and this was the paper which was published. And if we look at it, we can see that children with educational problems and children without educational problems, a substantial number of children with the BECT, benign childhood epilepsy, had significant educational problems. And this was correlated with the type of seizure, EEG abnormalities, and anti-epileptic drug usage, etc. So this is like a tip of the iceberg. We don't often see it unless we look for it. So I think it's very important that children who are under treatment, the physicians or pediatricians, pediatric epileptologists who are looking after these patients, be sensitive to the problem of cognitive issues in children with epilepsy. Look for cognitive problems and change the anti-epileptic drugs if required. We know that valproate can cause problems, phenobarbital can cause problems. If we are using these drugs, see whether an alternate drug will be suitable for these children. Now, cognitive dysfunction may be related to seizures, may be related to specific etiology like a Dravet syndrome or atypical benign, as I was now mentioning. I'm not going into this. Now, this was about the younger children I was talking. Is it only for children that this issue? No, it can have with the young adults, and also. We looked at later on, we looked at another cohort of juvenile myoclonic epilepsy. We often tell patients that, if somebody is to have an epilepsy, juvenile myoclonic epilepsy is probably the best one because it responds to drugs very well. They don't have any issues. They can live normally, so and so. But is it like that always? Juvenile myoclonic epilepsy, do they have cognitive problems or other issues? Dr. Srija and a team in Sri Chitra some years ago had looked at juvenile myoclonic epilepsy and tried to examine them, and when they look for frontal lobe dysfunction, and found that they have frontal executive dysfunction. That may impair their ability to learn, may impair their ability to function effectively. And is there a correlate for that? There is a correlate. There is a thinning of the cerebral cortex in the left frontal opercular area, the language area, in those patients whom we studied. So this is an important finding. Even when we think that juvenile myoclonic epilepsy is relatively normal cognition, they don't have any problem, go into details and we may find that there are patients who have difficulties. And this is not that they are psychological feelings, there is an anatomical basis for that. That's what we are trying to So it's very important to recognize this and handle it effectively. What about epilepsy and memory? Time immemorial, everybody was worried about the memory in patients with epilepsy. We believed initially that it was part of the condition epilepsy. Later on, we said that it is not part of the epilepsy, but medication related. And later on, we said now we are really considering how are we interacting so much. We know temporal lobe is the one which is handling most of the memory formation, learning and memory formation. A pathology in the hippocampus can lead to that difficulty in learning. And if there is bilateral pathology, that is seriously going to affect the learning and memory. So epilepsy patients may have significant memory. They may have verbal memory problems, they may have non-verbal memory problems. But I wanted to draw your attention to two other aspects. When we test patients with epilepsy with a traditional memory test, like Wechsler memory scale or Ray audits, these are the standard tests that we use to quantify the memory. There is not much of a difference in their memory. Okay. But still, these patients are complaining of, I can't remember, I have trouble with my memory. And we are also unable to understand why they are having memory problem, even when their tests are showing good memory. So here is where I have put in two things, two conditions. One is autobiographical memory, another is accelerated forgetting. This is a new terminology which has come in, accelerated forgetting. Until now, when we in our medical when we were in the medical school, we had learned how we learn and memorize. And we have never learned how we, what mechanisms our brain use to forget things. Is there a scavenger system that is making active forgetting in our human body? Apparently there is still not much literature that has come on. It's a very fascinating area. Perhaps there is a mechanism which is actively looking at the data and, okay, this is junk, let me remove it. This is not required, let me delete it. Like that, the brain is deleting also to make space for the new memories to form. So accelerated, this kind of memory, which is forgetting, which is normally happening, may be accelerated in people with epilepsy. It may also have something to do with the learning process, that the consolidation of the memory may be defective, so that the life of that memory's content may not be very good. It doesn't last as it should have. If it was supposed to last lifetime, but it may last only 1 week. So the way the memory is consolidated is defective. It is possible that it won't last long, and these patients may have memory problems. Now, our traditional memory tests, what do? They give us test and ask them to recollect things after half an hour. If they do that, they pass it. That is where the problem is. Half an hour, there is no issues. You test them after 5 days, 6 days, 1 week, 1 month, you find that there is problems. So that is what we are trying to look at in this kind of accelerated forgetting is picked up by looking at extended memory testing over a longer period of time, like 5 days or more. So that is one aspect. The other part is autobiographical memory. What is autobiographical memory? All memories related to a personal life are called basically autobiographical memory. Like my early childhood memories, my friends, the time I went to school, the first day in my school, or the later on in the high school or college, my marriage, my child, and so my employment, anything that is related. As we grow older and older, there is various stages in which we have a lot of autobiographical memories come. Okay, most of these POs are able to memorize it, but the details of it is what is the autobiographical memory is testing. Okay, your marriage day, you remember. What is the date of your marriage day? Most people will be able to tell that. Where was it conducted? Who all attended? How many of your friends had come in? What dress did you wear? What was the menu of the dinner, or the color of the bride's dress? The details of it, how vividly you remember. That part may slowly fade away. This is what is actually tested in the autobiography. So it's a very customized kind of memory testing, and you can find out very fascinating. This is just for I just said about the marriage. Similarly, we may say about the schooling on the first day. Tell me more about your first day in the school. Tell me who took you to the school. Where did you sit? And who spoke to you? Who was sitting to the left side, right side? Or who was the one who came to the class? And then when did you cry in your school? Like that, you go on asking questions, you can find out a lot of details. And in a systematic manner, there are standard questionnaires for that, not a free open kind of thing. So based on that, we may see autobiographical memory. Now, let me show the results of a study which we recently carried out in Sri Chitra. This is the autobiographical memory testing in a set of temporal lobe epilepsy compared to control persons. The orange color is control and the blue is temporal lobe epilepsy patients. Autobiographical memory of childhood. The entire autobiographical memory is divided into three parts: those related to childhood, early adulthood, and recent life. So if you look at it, the childhood autobiographical memory, although there was a little difference, the epilepsy group had a lower memory than the controls, it was not statistically significant. Now, when you look at the early adult life, there is a difference. P-value is 0.029. Temporal lobe patients had poor autobiographical memory compared to the controls. Now, when you look at older adult life, temporal lobe patients had significantly much more. P-value is 0.001, the difference. Now, these two are glaring. Why is that the childhood there is no difference? And my colleague, Dr. Pavan, was the Pavan Kumar Rudrabhatla. That is his full name. And he is in Vizag now. He's the one who has studied these patients. And he asked me, why is it, sir, that the childhood there is no auto? So that's when I also think, how come that is happening? Then it dawned upon us that, when does temporal lobe epilepsy normally start? It starts in late adolescence. The childhood area, there is no problem. So there is no memory problems. And from late adolescence, young adulthood onwards, there is problem, and which becomes more and more when they grow up. So this was a beautiful observation that autobiographical memory is so much dependent on the chronology and the disease condition. And if we measure these things, we can pick up problems. So when a patient complains to us that I have memory problems, don't dismiss it that, you shouldn't have, say that, you are really careless, don't worry about it, things like that. They may be genuinely having it, and set them into a training program to improve their memory and social lives. So that is about the memory part of it. The other comorbidity that goes with epilepsy is depression. In depression, we all know that the symptoms of depression and all, but in epilepsy, the depression is generally going undetected. That is the point. Many times we don't recognize that. So we need to develop specific questions to check whether they have depression or Why should we pick it up? Because depression can increase the seizure frequency. It can aggravate. So refractory epilepsy, if somebody is coming with refractory epilepsy, not responding to medications, it may be because there is an untreated depression under that. It may be affecting compliance, but even within good compliance, depression can have aggravate the seizures. About half of them in one study had a depression. There are several questionnaires now developed to assess depression in epilepsy specifically, and those things can be looked at. We can use those checklists to find out whether this patient has epilepsy and depression also. And what is more important is there are some drugs which may cause depression, and this should be avoided. These are the common drugs like vigabatrin, phenobarbital, topiramate, and levetiracetam. So when somebody is complaining of the depression or has depression and see whether these offending drugs are there, it may be a good idea to shift them from that to another drug. And some mood stabilizing drugs are also there, which may be handy because they control epilepsy as well as they take care of the mood swings, like lamotrigine, carbamazepine, and valproate also. So detecting and keeping in mind the possibility of depression is another important aspect of it. And it is also important to treat depression in people with epilepsy. It is important to avoid the TCA medications like amitriptyline, doxepin, because they might aggravate seizures. We can go for SSRI or SNRI and other drugs, and then they go ahead. And lastly, there was some question when I was looking into ECT. Can someone who's severe depression have ECT when the epilepsy is also there? It's not a contraindication. I just wanted to say, because some psychiatrist may ask whether can they give a ECT to this patient. So ECTs are not contraindicated in epilepsy. So there are a variety of drugs that can be used which will control the seizure depression and improve the quality of life and seizure control. Last part of my talk is about epilepsy. Do people die early? Normally, we tell children and adults that, you are not going to die from seizures. You will not die during a seizure. So that seems to be a very overconfident statement based on the data that is emerging. I think we need to be a little more realistic. If someone is asking, we should be careful in wording our how we word our ideas. At the moment, we can say that the life expectancy is reduced by 10 years for symptomatic epilepsy and by 2 years for idiopathic epilepsies. So 2 years in 70, or our lifespan now, life expectancy now is around 70 plus. So 2 years is not a gross difference. So, but in the case of symptomatic or structural pathology disorders, there is a 10-year difference. So we may be able to make a distinction there. And poorly controlled epilepsy carries always a higher mortality rate. How do people with epilepsy die? Interestingly, their risk of cardiovascular death is increased. Risk of stroke, alcohol dependence, and related deaths are increased. Some of them are preventable things. Some of them can be managed efficiently. Why should a person with epilepsy have increased cardiovascular risk? It may be because of the metabolic syndrome that might happen based on the drug therapy like valproate, which predispose to coronary artery disease, or it may be related to sodium channel blockers, which may produce cardiac block and lead to cardiac arrest, and that may be another factor. So don't dismiss these factors. When we treat a patient with coronary artery disease and has epilepsy, be careful while we choose our drugs. It should be a drug which will not be offending to the heart. I mean, sodium channel blocker can be a problem. It may be we should avoid a drug which may lead to metabolic syndrome, which may aggravate their cholesterol lipid profile and lead to problems. So we need to fine tune our treatment based on this. Other causes, epilepsy related deaths are accidents, SUDEP, and suicides. A couple of years ago, we did a study in in Sri Chitra Tirunal Institute about the death that happened in people admitted to the monitoring unit for the epilepsy monitoring. 10 years down the line, how many people have died? And we found that there were 15 deaths, out of which 5 deaths were SUDEP. 1/3 of the deaths that we came across were SUDEP. When I say we came across, I mean we were not able to track down all the patients who were admitted to SCT 10 years down the back. But whoever we could contact, their family or someone, we could finally find out that, out of some 600, I'm not put the details of it, some 600 or 1,000 patients, there were 15 deaths and 15 families we could contact, and that analysis, that 1/3 were SUDEP. So SUDEP is an important part of it, and I will just go and dwell it. SUDEP is sudden unexpected death in epilepsy. That means it is not a seizure, it is not a status epilepticus which is causing the death. It is an unexpected death which happens. It is divided now into probable, possible, and near SUDEPs. And also possible, the population-based studies show that 1 per 1,000 people with epilepsy may have SUDEP, and hospital-based shows that about 6 per 1,000. So it's not a very small number. The SUDEP determinants may be patient-related, treatment-related, or seizure-related. And severe epilepsies, young people, alcohol, and other recreational drugs, low IQ are the factors associated with SUDEP. And symptomatic epilepsy, type of seizures, polytherapy, and there was a concern that lamotrigine and carbamazepine maybe, because they are sodium channel blockers, maybe it is not at resolved, but at the moment there is not strong evidence to say implicate that these drugs are causing it, but it is still under scrutiny. One unit research group have come out with a SUDEP risk factor inventory. You go through these questions, and if the score is more than 4, then your risk of one person's risk of SUDEP is very high, and you counsel them accordingly. But I wanted to highlight one aspect here. Here is a person who has got seizures, and seizure is a focal seizure, EEG is showing bilateral seizure, that is going on. And the heart rate is normal there is a tachycardia. After the seizure is over, there is a bradycardia. The respiration is irregular. You can see that the saturation is dropping after the seizure is over. And PCO2 is mounting after the seizure is over. So if a nurse or a physician is standing by the side of a patient, what do we do normally? We turn them one side, suction and protect them and all those things. After the seizure is over, okay, fine, go, let me go, we walk away. Well, that is the time when he needs an observation. That is the time when the heart may decelerate and may go into an arrest. So ensure that somebody is looking at the pulse of the patient until he wakes up and sits up. This is important counseling to be given to all the family members. Family members should stay by the side of the patient and feel the pulse, and if there is, until they wake up and sit up. That will be about 20 minutes. So this part we should care. It's possible to prevent SUDEP to a certain extent, adjusting medications and seizure burden and all sorts of things which I have now mentioned. It may be possible eventually, but patient education the way somebody is lying down, prone lying down can cause SUDEP. So they should not lie down prone, rather they should lie down. So various ways of things. Should we tell about SUDEP to patients? As I warn them about the risk of patients? To tell or not, to wait or not to wait? This is always a debatable matter. I think we have to analyze it on the basis of case by case, situation by situation, and do not hesitate to discuss SUDEP, I would say. That is the best way to say that. Bring in that issue if they have some concern. Sometimes they may say that, doctor, something may happen to my child. You should not, or one, I should not, I should open up the opportunity to discuss SUDEP there and say that it's a very rare thing that might happen, but there have been reports like that. And mostly it is happening in persons with poor control of seizures who are not regular with medications, have other substance abuse issues and other things. And then also mention that somebody should monitor or observe the patient after the seizure is over. So these are some of the things that I have. So in this brief time, I had quickly gone through the new classification and the cognitive dysfunctions and depression and SUDEP related issues that are beyond the seizure matters in epilepsy. And thank you very much for the patient listening. And there is always a question, what is there? This picture I chose, is it a sunset or is it a sunrise? One may quick look, it may say that, it's a sunset, but actually it was a sunrise. So any situation can be looked at from two different ways, and you can look at it in a positive way and constructive way and handle it better. Thank you very much.
Thank you, Dr. Sanjeev, for your.
Thank you, Dr. Sanjeev. The most illustrative talk. I think he has spoken on the borders of epilepsy while going into epilepsy itself. Brilliant, as he always does. I think we'll take any questions at the end of the session. We'll now move on to the next talk and then come back again for the questions.
Thank you, Dr. Gilvas. Now I invite Dr. Arunyam Pillai, neurosurgeon and HOD, Medical Trust Hospital, to introduce Dr. George C. Villanidam for the talk. In between, a few words about Dr. നമ്മുടെ സ്ക്രീൻ ഷെയറിംഗ് ഒന്ന് സ്റ്റോപ്പ് ചെയ്യാമോ ഡോക്ടർ? ഓക്കെ, താങ്ക് യു. Next chairperson, Dr. Arunyam Pillai. He did his MBBS from Sri Krishna Medical College, Muzaffarpur, North Bihar. 2 years junior to me, he was. He did MCH neurosurgery from Sri Chitra Tirunal Institute, Trivandrum. Diplomate National Board Examination, that is a DNB in neurosurgery. Did FRCS in general surgery from Royal College of Surgeons, Edinburgh. Also did FRCS in neurosurgery from Intercollegiate Board, UK. Postgraduate diploma in hospital administration from Apollo Med, Quad City. He worked in many countries like UK, Saudi Arabia, Malaysia, Myanmar, and Brunei. Awarded Daraj Padua Sri Lailas Jassa title by the Sultan of Brunei for professional excellence. He had worked for a month in Peru, training the local neurosurgeons as an appointed delegate by the Foundation of International Education for Neurosurgeons of USA. Was an examiner for PhD thesis Apollo protein E in Alzheimer's disease for the University of Karachi. He has got also other interests, like he was also participated in the Flowers TV, Maiji Kodipadi, Urugodi in the last 2 days back, just 2 days back. An ardent fan of Bruce Lee and a traffic law enthusiast and whatnot. He had projected the doctor's agony in his Flowers show. If I will post it, in the YouTube link after this. So now I welcome Dr. Harun Manadathapillai, my close friend, to take over the session. Over to you, Dr. Harun. Please unmute and talk. Please unmute and talk.
Okay, thank you, Dr. Joy. I mean, that was too elaborate for a chairman. I think the emphasis should be on the speaker. I'm proud and happy to introduce Dr. Josh Vilandalam. He is now professor of neurosurgery in Sri Chitra Tirunal Institute of Neurosciences. He did his MBBS from TN Medical College, University of Mumbai, and MS General Surgery from All India Institute of Medical Sciences. He did MCS Neurosurgery from NIMHANS, Bangalore. He also holds an MBA in University of Madras and Medical Law and Ethics Postgraduate Diploma from the National Law School, Bangalore. He is also a fellow of the Royal College of Surgeons of Edinburgh in neurosurgery specialty. He is a mentor faculty for epilepsy surgery program at SGPGI, Lucknow, AIMS, Jodhpur, National Hospital, Colombo, National Institute of Neurology, Dhaka, Bangladesh, etc. He had special training in pediatric epilepsy surgery at UCLA, Los Angeles, United States, as part of the American Association of South Asian Neurosurgeons Ambassadorship Program. His research and publication fields include epilepsy surgery, morphometry of the temporal lobe, neurosurgical outcome audits, medical law and ethics, bibliometrics. He's quite passionate about enhancing surgical training standards and mentoring epilepsy surgery centers. He had trained neurosurgeons for developing epilepsy surgery centers in India, Bangladesh, Sri Lanka, and Nepal. His special area of interest includes epilepsy surgery, intrinsic brain tumors, eloquent brain surgery, neurosurgical training initiatives, bibliometry, medical law, and ethics. More than this description, I have a personal connection with Professor George. I am so unfortunate that I couldn't ever get a chance to work with this perfect gentleman. One of the regrets in my life is that I could never get a chance to work with this gentleman. I know George for quite some time, and more than a professor, he is like a younger brother to me. Anytime I need any help from Sri Chitra, automatically my fingers go to George Vilandalam's phone number. And if he's operating, as soon as he finishes surgery, before he writes the operation notes, first thing is he calls me back. I'm extremely grateful to you, George. And he's a wonderful speaker, highly knowledgeable, very humble, always ready to help. Professor George, over to you.
Thank you so much, Harun sir. And when this comes from such a versatile and multifaceted person, I think it's more honorable. Thank you so much for your kind words. Let me extend my profuse gratitude to Professor Dr. Joy Manjula and the Thrissur IMA for taking up this cause for people with epilepsy. Epilepsy is definitely a fortunate disease. If you compare it with many other illnesses that plague mankind, epilepsy has a lot of funding, a lot of international support. But then whatever said and done, I think meetings like this put forward and pitch the cause far and wide. And however hard we try, perhaps it's not enough. So let me start off by in a very, very simple way, by startling all of you, by telling you some very, very startling facts. As in the next 15 minutes that I'll be talking to you, 250 children will be born on this planet. And of this per minute 250, so it will be around 3,750 children will be born over the next few minutes of this webinar. 12 of them will have epilepsy. 4 of them will have drug resistant epilepsy. 3 of them are likely to benefit from curative epilepsy surgery, and one of those 3 patients would be living in India. But sadly, only one of 1,000 eligible epilepsy surgery candidates receive epilepsy surgery. So probably, all the one person who is going to be born in the next 15 minutes might never even reach anywhere near epilepsy surgery. So today now at this moment, I feel like a salesman in a car showroom. I'll tell you why. Because as I look through the 50 participants who are in this webinar now, I see that there are some general physicians I know, there are some pediatricians, there are some general practitioners, there are neurologists and neurosurgeons, there are some epilepsy surgeons as well, who perhaps have more experience than me in epilepsy surgery on this webinar now. There are administrators and a wide variety of people. So in a car showroom, there are probably 3 different types of people who come. Some who have, already fixed their mind on the brand. So they are coming to just decide on, what variety of that car they want. So do they want the highest end version, or they want to see those fine specifications? So that is the established neurosurgeon and the neurologists who are in this webinar. Now, some of them who are not really partially convinced about the car brand, so they are coming to test drive the vehicle. So those are probably the pediatricians and maybe the general physicians who are a little bit convinced about epilepsy surgery because they have someone somewhere of their patients who have received epilepsy surgery and done well. And then there are many others, maybe the ENT surgeon, the non-specialist, the other specialists who are not really convinced. So they'll just test drive and maybe if as a good salesman I can pitch the cost for the car brand, say a Volkswagen Tiguan, maybe I can sell the brand to them. So I personally now feel like the salesman in that high-end car showroom. So these are probably the 5 questions or 4 questions that come to everybody's mind who are attending this webinar now. Why surgery when anticonvulsants work well? Isn't surgery risky? Who is the best candidate for epilepsy surgery? When, where to refer for epilepsy surgery? Fair enough. This is a question that would come to anybody's mind. So let me answer them one by one. Why surgery? Because surgery offers a ray of a hope of both seizure freedom and anticonvulsant drug freedom. Isn't surgery risky? Everything in life is risky, as Harun sir said in his TV program a few days ago. But surgery is safe, efficacious, and the benefits far outweigh the risks. Who is the best candidate for epilepsy surgery? Drug-resistant epilepsy. We all know that the primary treatment for epilepsy is medications, but the concept of drug-resistant epilepsy has been evolving over the period of time. And drug-resistant epilepsy with a focal resectable seizure onset zone is the best candidate for epilepsy surgery. When and where to refer for surgery? To refer to specialized epilepsy surgery centers, where when you are convinced that it is drug resistant, you can initiate an early pre-surgical workup. So this is just a schematic representation of the global problem of epilepsy. The more red, the more is the problem of epilepsy. So epilepsy is, as we all know, a problem that is more heavy in the economically weaker nations. So it's more red in the African continent, while it is yet less yellow. The yellowish is where the high income nations where epilepsy is not so much of a problem. So 1 in 10 persons has the risk of a seizure in a lifetime. That is the epidemiological estimate. So this is just a schematic representation of, in our world, there are about today I think it's 7.8 billion people, of which 10.5 billion children have epilepsy. And if you see this big blue circle is the number of people in the world, it's not drawn to a scale. 3% have epilepsy. Of this, 0.3% have active epilepsy. Again, in that you have a small 25 to 30% who are drug resistant epilepsy. And in this drug resistant epilepsy, the surgeon's knife cannot cure all, but maybe about 70 to 80% will have some form of curative surgery options. And the rest of the others, we have palliative surgery procedures. So we have about 1 million people with drug resistant epilepsy in India as per the estimates today, and about 5 lakh children who may need epilepsy surgery in India. So let me just pick up a quote from the US president, who said that India is not just simply emerging, India has already emerged. So if you actually look at the history of epilepsy surgery in India, in a less formal way, it was first done by Professor Jacob Chandy in 1952 when he did the first hemispherotomy. We have very scanned records of this procedure. And officially, the first epilepsy surgery was done about 27 years back, 1995, at the R. Madhavan Nair Center by Professor Malla Bhaskar Rao under the leadership of Professor K. Radhakrishnan. So even now, though the number of eligible candidates is significantly high, maybe about 10 times this, maybe about 100 times this number, just about 800 to 1,000 epilepsy surgery procedures take place in our country per year. Now, why is it so? Now, if you actually look, there are a lot of dynamics into why epilepsy surgery does not really happen. It's not just lack of awareness. Probably the answer also lies in this slide. The economics of chronic seizures. If somebody takes anticonvulsants, this is what they would be spending per week, and this is what they would be spending the entire year. So the average cost of anticonvulsants per year is about 20 to 50,000 rupees, while the cost of surgery, a curative epilepsy surgery procedure, is usually a one-time cost. So in a government center like ours, the cost of temporal lobe dissections would be about 50,000 to 70,000 for a full paying patient. With invasive monitoring, the cost, invasive EEG, the cost goes up slightly high. So the answer to the previous question that I asked is that why epilepsy surgery hasn't penetrated far and wide is perhaps because of this economic dynamics as well. So which pharma company would want their revenue to be cut down by a single surgical procedure that would cure epilepsy? So you could think deeper about this further. And that is why perhaps the time or the interval to surgical referral in India, and probably even in some of the developed countries, even though the United States is a very, very developed country, out of the 50 states, maybe only about 25 states have a well-developed epilepsy surgery program. So it's not just that epilepsy surgery hasn't penetrated far and wide only in the developing world. Even in the developed countries, the story isn't much different. So the average time to referral is usually about 19 years, as found in a surgery a study about 25 years ago. But even now, the story is more or less the same. And this is the spectrum of surgically remediable epilepsy syndrome. I'll come a little bit deeper into this as we go further. Mesial temporal lobe epilepsy in adults is the commonest. We have lesional epilepsy due to tumors, due to vascular malformations. We have non-lesional epilepsy. We have large hemispheric epilepsy syndromes, and we also have a secondary generalized epilepsy. I'll go a little more deeper into all of them as we go further into the presentation. Now, Professor Sanjeev Thomas sir has very, very elaborately emphasized this concept that the tendency to have repeated seizures is what defines epilepsy, and seizure is an event while epilepsy is a disease. So every epilepsy or patient with epilepsy is like a mystery, a Sherlock Holmes mystery, and that is why Wilder Penfield, who's considered to be one of the fathers of epilepsy surgery, has said that epilepsy, though she wears the frightening mask of tragedy in her approach to each patient, takes off the mask before the physician who has the wit to stop and ponder her riddles. So this is a prescription from a primary health center. I'm sure all of us are familiar with seeing prescriptions like this, where the patient comes, you have 3 anticonvulsants going on, 6 months later, continue all. Sometimes the continue all is not even written by a physician. It might be just a pharmacist who's writing that and signing, and then the story goes on and on and on like this for you don't know how many years. So maybe at somewhere around this time, if somebody had considered the probability of drug-resistant epilepsy and considered referring to a higher center for a pre-surgical workup or a candidacy for surgery, maybe the story would have been completely different. So this is the definition, though this is a technical definition of drug-resistant epilepsy, taking 2 drugs appropriately chosen as monotherapies or in combination to achieve seizure freedom. And there are a lot of, this terminology, as Sanjeev Thomas sir was saying, epileptologists like to classify. So this terminology also keeps changing. So now they call it drug-resistant epilepsy. And I think there's a newer terminology now. It just keeps on changing. But the take-home message here is that you have at least 2 given drugs. But then again, this concept is also changed further. And, if you have, you wait for long, you also have a concept of surgically refractory epilepsy. So here you have the pacemaker of the network, and here you have the network. So after some time, what happens is that though, even if you take out this pacemaker surgically, there would be other areas in the network which are independently epileptogenic due to the phenomenon known as secondary epileptogenesis. So that is when the concept of surgically refractory epilepsy comes in. And that is why, we definitely should not, rely too much on delaying surgical referrals. So that's why somebody has said that tomorrow, you always keep delaying some of these things which you're not comfortable with for a future date. That's why somebody has said that tomorrow is a mystical land where 99% of all human productivity, motivation, and achievement is stored. So the message which I want to tell you is that if you think that your patient is going into surgically a drug refractory state, please refer early to consider the possibility of surgical candidacy. So if you refer late, this could be probably what happens to children, the concept of epileptic encephalopathy, so many syndromes, where you have again multiple areas, a progressive cerebral dysfunction due to epileptiform abnormalities. But fortunately, there is a good surgical outcome even in carefully selected epileptic encephalopathy. And then you have the other spectrum like this, where you have, this is a little child who had continuous seizures, a refractory status epilepticus. He underwent a tracheostomy, and the root cause of it was his entire right hemisphere, which was burnt out due to Rasmussen's encephalitis. But an emergency epilepsy surgery cured him of his problems, and now he is significantly functional off the tracheostomy due to aspiration pneumonia and almost fully functional. So epilepsy surgery, now the concept is changing, is no longer the last resort, because we know the natural history of many epileptogenic lesions. So you don't really have to wait for 2 years for 2 drugs, because the concept of there is an individualized definition of refractoriness for each patient. So now suppose you have an airline pilot or a neurosurgeon who has even 1 seizure in a year, that could be significantly disabling, not just to him, but to many others around him who depend on him. At the same time, if you have a mentally challenged young girl who has from say 10 seizures, the seizure burden increasing to 15 seizures, maybe that may not be very, very significant. So you have an individualized definition of medical refractoriness and the concept of surgically refractory epilepsy. So these are some few key concepts. So the most important central concept in epilepsy surgery is finding a focal area of the brain from where the seizures develop and resecting it without causing an unacceptable deficit. So unfortunately, this is easier said than done. So the cornerstone of epilepsy surgery is what is known as the epileptogenic zone. That is this area given in red. So this epileptogenic zone is not equivalent to the MRI abnormality. That is what makes epilepsy surgery quite different from the rest of neurosurgery, wherein everything is MRI structural abnormality based. So here you have some other zones. You have got a symptomatogenic zone, which is the area responsible for the symptoms after a seizure, where the seizure spreads. You have an irritative zone where you have an interictal or a discharge which is coming continuously after the seizure. You have the epileptogenic lesion. So finally, what is the epileptogenic zone is something which you would know only after surgery, because you have resected the zone only when the patient is seizure free. And at the same time, there are some patients who have a partial resection and still good seizure outcome. That is because of the concept of a network. So a network sometimes gets disrupted even with a partial resection of some lesions, like say hypothalamic hematomas or many other types of lesions. So, this is probably some of you may recognize this gentleman. His name is Captain Smith, and he was the captain of the Titanic. So, we are the epilepsy surgeons sometimes are like Captain Smith. We just see the tip of the iceberg and we forget the complex epileptic network which lies below the iceberg. And, that is where we sometimes hit the iceberg and sink the ship. So this is exactly how the scenario is in most of the patients with epilepsy. What you see on the tip, that is the MRI abnormality, is usually not really suggestive of the complex epileptic network. So the soul of epilepsy surgery is to resect the epileptogenic zone, which is not equal to the MRI lesion, not equal to the electrocorticographic or the EEG abnormality, not equal to the SPECT or the PET abnormality, and it is a little bit of everything. And to resect a little bit of this everything at the same time preserve the function of the patient is a very, very tall proposition. So the hierarchy of the pre-surgical workup. So when you feel that a patient requires a pre-surgical workup, he is medically refractory, refer to a center where the basic pre-surgical workup is an MRI done as per a particular epilepsy protocol, a video EEG, which is both the usual EEG with a video recording of the semiology. So we can correlate the actual seizure with the electrical abnormality. And most of the patients, you will be surprised that 80 to 85% of decisions on epilepsy surgery are done with just these two investigations. So it is just, you should not be carried away thinking that you need a lot of sophistication to work up a candidate for pre-surgical, for candidacy of epilepsy surgery. So this PET scan or SPECT scan is an invasive monitoring, that is placing electrodes directly on the brain, is the next echelon of investigation, which probably can be done at the highest level epilepsy surgery center. So they call it perhaps a level 4 center, but most of the basic workup, 80 to 85% of patients, can be done with just an MRI and a video EEG. So the buzzword is to have a concordance. In other words, your electrical abnormality and the imaging both need to meet together. And when you have a concordance, that is when you have the best surgical outcome. So from a surgical viewpoint, maybe we can classify epilepsy as generalized or localization related focal, and the one that you see here in red, symptomatic localization related epilepsy, is the one which helps us to identify the surgical candidates. So surgically remediable epilepsy syndromes, as I emphasized earlier, the prototype of which is the hippocampal sclerosis or mesial temporal lobe epilepsy, where you can actually offer surgery early without waiting for the typical 2 years duration. And the candidate for epilepsy surgery, not just medical intractability, you also have other associated factors, loss of quality of life, anti-convulsant side effects, all these things which makes you identify a candidate early. And the outcomes which we are looking for are definitely seizure freedom tops the chart, but many other factors. Now you have so many factors which are directly or indirectly connected to seizure freedom. And sometimes it happens that, we see some patients who are completely seizure free after surgery, but then they are not really happy. That is where, there is a concept of a burden of normality. And there were some extremely intelligent and geniuses in history who actually did many creative things during their seizure attacks. So they are the people who really sometimes, even though you might have seizure freedom, sometimes it does not always correlate with a happy patient. So outcome measures are definitely interrelated to seizure freedom, but not always entirely related to seizure freedom. So this is the score that we use for evaluating the success of epilepsy surgery, an Engel score described by Professor Jerome Engel. So you have class 1, class 2, class 3, class 4. Class 1 is the best outcome, while class 4 is no worthwhile improvement. So this is the pathological spectrum of the usual surgical remediable epilepsy. Cortical dysplasia, which is an architectural abnormality in the brain. I'll show you a few histological slides to illustrate this point. A low-grade astrocytoma. Then we have what is known as long-term epilepsy-associated tumors, that is DNET, dysembryoplastic neuroectodermal tumor. And then we have ganglioglioma. We have some vascular malformations like cavernoma, post-traumatic gliosis, and of course the AVMs and the tubers associated with tuberous sclerosis. Focal cortical dysplasia is an architectural abnormality. The International League Against Epilepsy has classified it into type 1, type 2, and type 3. I wouldn't go to too much of the technical details, but I'll show you a picture. This is how the focal cortical dysplasia looks like. There is a gray matter thickening which is seen here, and if you see there are 6 layers of the cortex which are thrown into a disarray. There are highly epileptogenic cells called dysmorphic neurons which are seen here. So this is the history of epilepsy treatment. So most of you perhaps would already know that epilepsy surgery is older than the MRI, older than the EEG. So the first epilepsy surgery was actually done by Victor Horsley purely on the basis of cerebral localization. A cortical scar resected at Queen Square Hospital, London in 1885, probably almost 100 years or even before the X-ray was discovered. So by William Röntgen in 1900. So you can imagine epilepsy surgery is probably as old as the history of neurosurgery per se. So these are some of the pioneers of the progress that we see in epilepsy surgery today. Wilder Penfield from Montreal Neurological Institute. We have Huglings Jackson, the neurologist who helped Horsley to localize, and Hans Berger, who is considered the father of EEG, Ghazi Assergill, the neurosurgeon who innovated microneurosurgical procedures. So this is this whole histological spectrum of epilepsy. We shouldn't forget from the simpler lesions like neurocysticercosis and tuberculoma when we see so many of the complex syndromes. So this epilepsy surgery resections can range from a small lesion, the extended lesion, a single lobe, the multi-lobes, or probably the entire hemisphere as well. So when we talk about pediatric epilepsy surgery, we should remember that children are a little different from adults. Though we always say that children are not little adults, I don't completely agree with this statement, because some things about children, especially the basic principles of epilepsy surgery workup, may remain the same. But what is different is that they have a plastic brain. So they have great tolerance for large resections. So if you resect the speech area in their brain, tomorrow an adjacent area can probably regain that function, and the child may regain the speech function. And there is a greater cumulative insult of refractory seizures in children. So in children, we have more of extratemporal epilepsies, we have more of perinatal injuries, we have Rasmussen's encephalitis is a separate subset. And we have more of extratemporal epilepsies and cortical malformations in children. And we have in adults, 60 to 70% of epilepsy is still temporal lobe epilepsy. So sometimes you have, very, very small children, maybe 1 or 2 month old infant who is already low birth weight. You really don't know whether, he's continuously throwing seizures. Is he a candidate for epilepsy surgery? That is when this path-breaking statement by a pediatric epilepsy surgeon throws some light, who says, Dr. Gary Mathern, who says that no age, weight, or size is too small for epilepsy surgery if the seizure burden so demands. So key decision making is based on the seizure burden and the probability for a good surgical outcome. Now I'll quickly run you through a few pictures. The spectrum of lesions. This is a cingulate gyrus AV malformation in a child, which can cause refractory seizures, and after surgery did well. This is a ganglioglioma in the occipitotemporal region, medial occipitotemporal region. This is a multiple dual pathology. You have a gliosis here, you have a medial frontal focal cortical dysplasia. So it's a tough task to find out which of these two is responsible for the chronic seizures. You have again a cortical dysplasia here in the medial frontal region. You have a cavernoma in the insula after surgery, which has been resected safely. You have got a parieto-occipital gliosis, which is known as a posterior quadrant gliosis. And this is the poor man's PET scan, a new MRI modality called the arterial spin labeled MRI. We have Professor Gilvas and most of the expert neurologists like Dr. Sanjeev Thomas sir would be actually able to obviate the need for too much complex imaging, because they are able to localize based on the semiology itself where the seizure is originating from. And the bread and butter for epilepsy surgeons is the temporal lobe. Why the temporal lobe is so special? Because it has got developmentally all the three developmental areas of the brain: the allocortex, the mesocortex, the neocortex. It is part of the limbic system. And temporal lobectomy is also special because it is perhaps one of the few procedures where there is class 1 evidence, a randomized controlled trial by Professor Wiebe, who actually proved that epilepsy surgery is beneficial. No other procedure in neurosurgery has got class 1 evidence to support it. So the epilepsy surgery, the temporal lobectomy, I'll just quickly run you through that. Previously, the old concept was to resect more of the lateral lobe and less of the medial lobe. But now the concept has evolved in the current era by Spencer, where we resect more of the medial lobe and the less of the lateral lobe. So this is the current standard of care: 4 centimeters of the dominant lobe, 5 centimeters with amygdalar and hippocampal resection. I'll quickly show you an interesting case. This is a 23-year-old female, a very, very productive girl who has studied up to, she's a graduate, a commerce graduate, and she's been having seizures for 8 years, not able to get married. MRI video EEG was done as part of the pre-surgical workup, and the MRI showed a very, very nice concordance. That is, seizures building up from the right temporal lobe, a nice hippocampal sclerosis, a bright area on the right side of the hippocampus. This is the usual incision that we give, hair preserving surgery. Patient is in the supine position under general anesthesia. And I'll quickly show you a video. We do an intraoperative electrocorticography monitoring. This is the craniotomy done. The dura has been opened here. This is a grid electrode placed on the brain. This is the Sylvian fissure. This is the anterior temporal lobectomy being done. I'll just fast forward the video in the interest of time. The pia being cut open gradually, gently. And here the temporal lobe resection is going further. And we have a en masse resection of the temporal lobe, which is being done. The temporal horn of the lateral ventricle is gradually being dissected open, because that is what leads us to the hippocampus and the amygdala. And once that is done, we place depth electrodes to measure the discharges ictal activity from the hippocampus and the amygdala. And here we have the amygdala being resected gently in a piecemeal manner, and the hippocampus being gradually, you can see this hippocampus being gradually dissected off by opening the choroidal fissure. And here you can see the hippocampus being everted, the head of the hippocampus. Hippocampus is like a seahorse. You could see the seahorse shape here very nicely. The head of the seahorse, the body of the seahorse, is the tail of the seahorse, and this is the resected hippocampus. So this is how the neocortex or the temporal lobe looks like. And the amygdala, which is an important area of mediating anger and fear in the normal patient, but in this case it's a diseased amygdala. And this is how the resected hippocampus looks like. And we have selective resections where the medial temporal structures, without removing the rest of the temporal lobe, are also resected. And these are sometimes extended resections, occipital lobe also required along with this. So neuropsychological outcomes are also very nice, because the patients usually are already significantly disabled cognitively because of lot of high dose of anticonvulsants. After surgery, when we can reduce the anticonvulsants, they do significantly well. Visual outcomes, sometimes there may be a small quadrant anopia, but it's very, very rare, and it's a small price to pay for a significant improvement in the quality of life due to seizure freedom. So sometimes the seizures may come from outside the temporal lobe. That is when we sometimes need invasive monitoring. It could come from the insula, the orbitofrontal cortex, that's known as temporal plus epilepsy. Some patients require large resections, multilobar resections, and they look like this on post-operative scans. And one of the procedures commonly done in children is hemispherotomy. I know it sounds a little scary, but the common concept is to interrupt the cortex from the thalamo-basal ganglionic system. And these are some of the syndromes: Serge-Weber, hemimegalencephaly, cortical dysplasias, Rasmussen's encephalitis, for which this disconnection is usually done. And usually the prerequisites are that you should have a opposite or a non-epileptic hemisphere, which is structurally and functionally normal. And again, the concept of brain plasticity, where you have recruitment of neurons to perform an electroend function that is not destined to do. This is the typical example of plasticity in a young boy who underwent a hemispherotomy. If you look here, his whole right hemisphere has been epileptogenic and has been treated surgically, but he's still able to perform functions. That is because the function has shifted to the opposite hemisphere. In fact, his left hemisphere performs the function of both the hemispheres of the brain, and half a brain is good enough for him. And the concept has been changing from large resections to disconnections over a period of time. So this is just a schematic disconnection of the thalamo-basal ganglionic system from the cortex, which is the cornerstone of hemispherotomy. And this is the morbidity of drop attacks or chronic seizures, where the patient has multiple injuries on the face and the forehead. And these are patients who may benefit from a palliative procedure called corpus callosotomy, where we interrupt the spread of seizures from one side to one hemisphere to another, and there is no definite resectable focus on one side of the brain. These are the commissures of the brain which are disconnected as part of corpus callosotomy. And drop attacks, Lennox-Gastaut syndrome, these are the usual indications for a callosotomy. And this is how the callosotomy is actually done. There's no time for a video, but I'll just quickly show you a picture. This is the hemisphere which has been retracted. This is the fox between the two hemispheres. This is the white corpus callosum, which is disconnected as part of a callosotomy. And this is the schematic representation of the surgical steps of a callosotomy. And at the end of callosotomy, we also disconnect the fornix, which is an important commissural fiber. Multiple subtrapeal transection is another procedure which is done mainly with a palliative intent, where eloquent or functional brain areas are again interrupted from the rest of the neuraxis. Vagus nerve stimulation is actually a very, very simple procedure, but it is usually done with a palliative intent, where you place a stimulator in the vagus nerve in the neck. And in Europe and many of the centers in the West, these are actually done by general surgeons, not by neurosurgeons or any other specialized epileptologists. And the concept is to inhibit the epileptogenesis by multiple stimulations of the vagus. And this is the stimulator placed in the neck. And this is done as a palliative procedure, and its outcomes are not very exciting, but maybe 50% of patients have got good seizure outcome benefit, at least with the palliative intent. And many patients, about 10 patients, require invasive monitoring, that is placing electrodes directly on the brain so that you can exactly localize where the seizure is coming from. This is how it used to be done in the past with a craniotomy, but now in the current era of, we have the concept of MRI negative epilepsy. This is a patient who had a very focal seizure in the brain, if you see here, but the MRI was completely negative. So in this situation, this is a video EG. I'll just run through it quickly. So the patient had a small seizure attack and he recovers almost immediately, but he's significantly disabled due to this. And we had to place electrodes directly in the brain, 10 stereo EG micro electrodes to localize where the seizures are from. And we found that the seizures are exactly from the left side insula. And we had patient underwent a insular temporal resection and did significantly well. So these are some of the clinical scenarios where we do invasive EEG monitoring, and this is how the brain sometimes looks during an invasive EEG monitoring. Awake surgery is occasionally done when we have eloquent area lesions, and awake surgery has been brought out by the press several times with the patient doing new activities during awake surgery, sometimes playing the guitar or sometimes doing so new limits are being set what is being done during awake surgery, and it's a sensational procedure as far as the layman goes. But we always remember that sometimes, even though we are trying to avoid a neurological deficit, for the greater gain of seizure control, sometimes a small deficit like a non-dominant hand weakness is a small price to pay. And that is when sometimes patients, when we talk to them and we explain to them about this deficit, they understand fully that these deficits are not full and final, especially non-dominant limb weakness, which can significantly improve over a period of time. One of the other lesions with which I'll be ending this presentation is hypothalamic hamartomas. These are complex lesions, sometimes presenting with precocious puberty, behavioral disturbances, gelastic epilepsy, and it's a complex network. Sometimes this is the enigmatic mirthless laughter, which is part of the gelastic seizure, and this is how they look. They could be small, they could be very large, and they do very well with surgery. And in general, the surgery outcomes are best with temporal lobe epilepsy in epilepsy surgery, while extratemporal, it's usually around 60 to 70%. And even the adverse events are extremely within the range of the general neurosurgical procedures and perfectly acceptable. And the outcome of epilepsy surgery is best for lesional temporal and for hemispherotomies. And what is new? A lot of new things are happening in epilepsy surgery: thinner electrodes, image guidance. You have newer treatment options like lasers, you have radio surgery, you have robotic surgery, you have deep brain stimulation. One of the new kids on the block is responsive neural stimulation, where you place an electrode which is a closed loop stimulation, which actually picks up a seizure, preempts it and aborts it. So this is something which is FDA approved and coming up in a big way. Very expensive for our patients, so we haven't used it so far. And deep brain stimulation, which is already the standard of care for Parkinsonism, has also found a small footing in epilepsy. Though the epilepsy targets are very large, this probably is an option for patients with primary generalized epilepsy, and the target here is the anterior thalamus as against the subthalamic nucleus in Parkinsonism. And some of the emerging frontiers are now probably less resection. You have DBS stimulation, you have newer options other than resective surgery, lasers, radio frequency. You have less invasive endoscopic and minimally invasive hemispherotomy and callosotomy described. You have thinner electrodes. The previous electrodes which we used to put used to be 1.1 millimeters. Now the stereo EG electrodes are 0.8 millimeters. And some of the newer electrophysiological advancements, one of which is high frequency oscillations, which can be picked up only with specific small sensors. And these probably can pick up the epileptogenic zones. These are usually in the frequency range beyond 60 hertz, and they can probably be biomarkers for epilepsy. So, epilepsy surgery is definitely requires a very, very committed team, which has all these members on board, and each one has got a unique role, and each one's contribution is immense to have this success. And these are the members of our team in the epilepsy surgery program: Professor Radhakrishnan, who developed it; Professor Sanjeev Thomas, who carried it forward and did some phenomenal work in women with epilepsy, especially in pregnancy; Professor Matthew Abraham, Dr. Ashalata, Dr. Ram Shekhar, Dr. Bijoy Thomas, Professor Keshav Das, and Dr. Ajit. And let me end with a very, very important message that this is a very underutilized subspecialty, and 25 to 30% of epilepsy patients are drug resistant. And the moment you sense this, whichever part of the world you are practicing medicine, please refer to a specialized epilepsy surgery center to consider the possibility of surgical candidacy. 2/3 of these drug resistant probably will be candidates for curative epilepsy surgery, and some of them may have palliative surgery options. And the cornerstone of epilepsy surgery is to resect this conceptual epileptogenic zone without any deficits or with acceptable deficits. And every patient's epileptic network is unique, and we have to think beyond the MRI abnormality that we see. So let me, sometimes when we have difficult patients in epilepsy, this is a very, very inspiring quote that we always remember, that it is impossible, said pride. It is risky, said experience. It is pointless, said reason. And finally, give it a try, whispered the heart. Let me thank you all very, very profusely from the bottom of my heart, especially the Thrissur IMA leadership, for spending time to understand how we can make a difference in the lives of people with epilepsy. Thank you very much.
Dr. Harun?
Thank you, Professor George. As usual, it was a very lucid and very complex topic presented in a very simple manner. Hats off and appreciation to you. Now, I don't find any questions in the chat box, but I'm sure somebody may have any questions. If there's any questions, feel free to ask.
Screen sharing. Yeah.
Okay, I can stop it.
Somebody had asked a question about recent interest in keto diet in seizures. I think it's for Professor Sanjeev Thomas. Keto diet in seizures, any role?
George, I think you should answer that question because it is related to refractory epilepsy. I can also share some. Would you like to take on that?
Keto diet, sir, is not something which competes with epilepsy surgery per se, but then we have a few candidates who have primary generalized epilepsy surgery who may not qualify for a focal resection. So these are patients who sometimes you have 4 or 5 anticonvulsants going on, and then they are desperate to cling on to any string or any rope that you throw at them. So I wouldn't say keto diet is not effective. There are a few patients who have used it who are doing extremely well, but these are those patients who usually don't qualify for a curative surgical resection. And there are centers in India which are specialized in keto diet. I think there's an expert in Mumbai. I'm not able to recollect the neurologist's name, who is an expert in keto diet. And definitely keto diet has a role.
Janak Nathan.
Yes, sir.
Okay, thank you, George. The next question is, when is SPECT CT scan indicated in patients with epilepsy?
Sir, Sanjeev sir, shall I answer it?
Yeah. So right. It was a pleasure listening to you. It was a music listening to you, George, and you go ahead.
Thank you, sir. So as I emphasized, whenever we use words like PET, SPECT, and MEG, there is a lot of sophistication that comes into epilepsy surgery. Definitely, when you have a lot of sophistication associated with it, it tends to keep away the general neurosurgeon, or it tends to keep away less equipped centers. So that is not the message that should go across, because even now in India, 2/3 of adult epilepsy surgery is temporal lobe epilepsy surgery, and 85 to about almost 80 to 85% of patients can be worked up with just 2 basic investigations, that is a MRI and a video EEG. Now, there are even papers which say that for typical hippocampal sclerosis, you can even obviate the need for a video EEG, and just a scalp EEG is enough. So coming to the point here, that is the need for SPECT, still there are 10 to 15% of patients who may need the next level of investigation, and definitely the less invasive it is, we would prefer that. So PET, that is an interictal PET or a ictal SPECT, usually is a functional imaging which shows some form of an ictal interictal hypometabolism or an ictal hypermetabolism, which which helps you to localize the lesion. So it does not have that sort of an accuracy which a structural imaging has, but it helps to lateralize, it helps to localize to a large extent, especially useful in patients who have some form of ambiguity or some form of dual pathology, where you have some discordance in the video EEG and in the MRI imaging. So for 10 to 15% of patients, like usually those with cortical tubers, multiple tubers, where you don't know which lesion perhaps is more epileptogenic, where that is where PET and SPECT has got a role in further evaluation. And even that, if that is ambiguous, the next echelon of investigation is the invasive monitoring, that is placing electrodes directly on the brain.
Okay, thank you, George. Now, I have got a few questions for my own information. You said surgically refractory epilepsy. How do you decide pre-op whether the patient will be surgically refractory or not?
That's a very thinking man's question, Harun sir. So I must confess that it's very, very difficult to say. But then there are some conditions like, these epileptic encephalopathy syndromes, where when you have got generalized EEG abnormalities, that is a negative prognostic factor. But again, we offer surgery because then we don't have any other options. One, we are exhausted of options. So give it a chance. So that is how we sometimes, it is difficult to predict preoperatively. Many patients surprise us with their outcomes. At the same time, many patients whom we expect to do well, occasionally due to unresected, unknown foci from other areas, might not do well. So the key point here, which about surgically refractory epilepsy, is that the basic take-home message is that the later the surgical referral, usually, especially for established surgically remediable epilepsy syndromes like hippocampal sclerosis, outcomes are not as good as the earlier referred patients. At the same time, there is a concept of running down of seizures. So if you have, suppose some of them who are not clear surgical candidates, sometimes you wait for the natural history to evolve and see, maybe they might have better options. So in that situation, perhaps waiting when they have multiple pathologies or a large unresectable lesion which can cause an unacceptable deficit, in those situations perhaps waiting will help. But the general concept is that for the delayed more delayed your referral, for surgically remediable epilepsy, typical surgically remediable syndromes, the outcomes are worse. In fact, even surgical outcomes.
Thank you, George.
Now we have 15 to 20 years outcomes, which say that even the good outcome cases with hippocampal sclerosis, after 15 to 20 years, there are a few patients who have a redevelopment of the recrudescent epileptic network. So earlier surgical options, earlier referrals definitely is the message.
Okay, thank you, George. My next question is, when it comes to lesionectomy for refractory epilepsy, for example, gangliosarcoma or DNET, how do you decide the extent of excision? Is it just the lesion or you go by electrocorticogram information?
Yes, sir. That's a very good question. When we have certain lesions like low-grade gliomas, a typical epilepsy-associated glioma, like long-term epilepsy-associated tumors, gangliogliomas, DNETs. So these tumors and also some cavernomas and glioma and some gliosis, these are known to have surrounding areas which are cortical dysplasia. In fact, there is a classification of cortical dysplasia where there is a type 3 cortical dysplasia, which is associated with lesions. You have type 3A, 3B, 3C, 3D. So when we suspect lesions to be associated with cortical dysplasia, we usually use intraoperative electrocorticography, and based on the post resection. So we resect the MRI abnormality. That is the first stage. Once we resect the MRI abnormality, cortical dysplasia surrounding the lesion, that is probably for a cavernoma or for a DNET, we resect that. That is based on the structural abnormality that we see and based on the electrical abnormality that we see in a electrocorticogram, acute intraoperative electrocorticogram. But the message here is that we are not going to extend the resection into eloquent areas just because we find some electrical abnormality on the intraoperative EEG. We are not going to do it at the cost of giving an additional deficit.
Okay, thank you. One last question from me. You told about DBS and the closed loop system. So can you tell me what's the difference between these two? These are implantable electrodes which work by itself. So
Right.
what's the difference?
The DBS, it's like it's a open loop system wherein you here what the closed loop system does is that it actually senses. There are two aspects to this. One is a sensor which actually continuously monitors EEG, and it is programmed to detect a pre-seizure or detect an something like an electrical activity which comes with an aura. And as soon as it detects it, it actually stimulates by using either radio frequency ablation or electrical stimulation and aborts the seizure. So that is how a closed loop stimulation works. While in an open loop stimulation, you have already previously set it. You're not, that is usually done for as part of DBS for Parkinsonism, where you actually have set it at a particular predetermined voltage, and you are going to continuously keep stimulating at particular intervals, irrespective of whether there is a seizure coming or no.
So basically, closed loop system is a supply on demand.
That's right.
The other one is a continuous supply.
Continuous supply. That's right.
Thank you, George. Now, Dr. Gilwas.
So I'm a pediatrician. One of my questions to Sanjeev sir. So Sanjeev sir, about the SUDAP, it's not a pediatrician's territory. My doubt about your last slide showing the cardiac and the hypoxia, hypercarbia part of that curve, that definitely shows that the short period of respiratory cessation is there. So what is the basis of this SUDAP? Is it a sudden death due to cardiogenic or more of respiratory center problem leading to a significant prolonged apnea leading on to death? What are the evidences in the postmortem? Is there anything documented in the respiratory center in those cases of SUDAP? And one more thing, that's a situation whether there can be an intervention just like what you do in a pediatric age group. It is almost equivalent to SIDS, and we are not, again, don't know what exactly is it. In such a situation, among the interventions, something like apnea monitors, husband and wife sleeping, and the moment the apnea episode is alarm, and she can do some intervention. Like that, is there any interventionable matter sought? And just like from the point from the Dr. George's suggestion, the detection and intervention combination, just like the electrophysiological cardiac problem, the automatic implantable defibrillator-like situation, that's what you are using for the detection and treatment simultaneously for the EEG, the seizure part. Whether such sort of a thing can be used for this respiratory center mediated problem, apnea, then some intervention. That's one question for sir.
Thanks. Thank you for that. Thank you for that question. There is a lot of research into the mechanism of SUDAP, and now we know that there are multiple factors which are involved. Autopsy studies have shown features of pulmonary edema in many patients. Blood reports have shown subtherapeutic levels in many of these patients. Hemodynamic monitoring, as the one which I showed, have shown that there is a cardiac deceleration which might happen, an arrest can happen, or a respiratory arrest can happen. So the medullary centers for cardiac rhythm and respiration are close to each other, and these centers may get suppressed during a seizure, and there may be a failure of recovery of these centers to operate during a seizure. This is one of the mechanisms now proposed, and That is why the pulse and other things have to be monitored. The point of whether we can do some sort of a stimulation is now being actively considered. There are monitoring units which are, interestingly, this recent data has come mostly from epilepsy monitoring units, where the patients are continuously monitored for 6 years. And during that time, they have a SUDAP. The nurse has given the food and was gone to the next room and then comes back to know that there was a death. So analyzing those EEGs, there is a MORTEM study, which has multicentric study, which has come out with a lot of data on the mechanism of this SUDAP. So multiple pathways finally channeling to a brainstem suppression is one of the proposed mechanisms. Other is, as I mentioned, sodium channel blockers like lamotrigine or carbamazepine may be aggravating the situation and cause seizures. Some intervention viewpoint, monitoring and intervention, this apnea and the cardiac rhythm suppression, saturation dropping, these are things which can be monitored and which can be recovered, people can be alerted, and definitely there is a lot of things going on in this area. I must mention 2 persons' names here. One person at least, Dr. Rajesh Ramachandran. He is a pediatrician who did his DM from NIMANS, and he was working in Calicut Medical College for some time. Afterwards, now he is in Canada. He has done a lot of work on a community level SUDAP studies, and based on that, some recommendations have also come out. So SUDAP is something which we need to follow up, and there are positive interventions. That's why it is now called, can we prevent it? Yes, we can prevent it. New methods are there. And when we looked at the 15 cases of death, 5 cases of death which we had, many of them were actually in daytime. The mother had fed the child, gone to the next room, and then half an hour later came back and found the child died. There was no telltale evidence of a seizure. Child did not fall down, and so they had a sudden arrest. It is not necessary that they should have a seizure prior to the death. That is also important. SUDAP is not that an undetected or an unobserved seizure from at the end of which the child dies. No, it is not necessarily like that. The child can simply die without a seizure also. Child or adult, both.
Thank you, Dr. Yeah, this is from Dr. Parvati. Yes, please.
I am Dr. Parvati, Dr. K. Radhakrishna's classmate. Yeah. I have a doubt to Dr. George. That is, regarding plasticity, you have mentioned that maximum up to 6 years of age, but the child you have shown is much older.
Yes, madam. What I meant was that the best plasticity is, the younger the patient is the best plasticity, but plasticity happens even in adults. In fact, the recent research in plasticity is actually divided into 3 parts. It is even says intraoperative plasticity, and then early postoperative plasticity, and late postoperative. So in fact, they say that even when you are resecting the eloquent area in children, there is even intraoperative plasticity. So immediate post-op itself, you might see that a lot of function has actually recovered. So though the best outcome is less than 6 years, it even happens in adults.
Okay,
so
thank you.
That is why the important message here is that though we even sometimes if we have a post-operative deficit, it happens even in other neurological conditions. Like you have a lacunar stroke, that your relative with a lacunar stroke who had the stroke yesterday is not going to be the same 1 year from now, because you have got so much of improvement which happens due to several reasons. Plasticity is stimulated by your post-operative physical therapy, post-ictus or post-disease physical therapy. So it's a dynamic process. So it happens even in adults, though it is best in children.
What is your experience in hypoxic ischemic encephalopathy seizures following hypoxic ischemic encephalopathy in the newborn?
in the newborn? I think Sanjeev sir will be in a better position to answer that. After that, I can tell you my experience with the surgical patients.
This is a very important matter. HIE is one thing which may lead to occipital lobe epilepsy in in older childhood, and some of them may have bilateral pathology, but one side may be more affected than it. During our pre-surgical workup, we may be able to show that one side of the occipital lobe is the real cause of the seizures, and an operation there can ameliorate the seizures. The next question is, will vision be affected? So we can do a standard visual field charting and see what is the vision, and then we can also look at certain other functional vision testing to see where is the vision right now. Is it in the affected area or is it a little away from there? And plan out the resection areas. So this is right now a very lot of surgeries we are operating in the occipital lobe. That I think George will tell. So the procedure is about looking at the imaging followed by the EEG, going back to the patient, visual field charting, assessing again, and coming. That is the way we go.
Just to add a few points from a surgical perspective, in hypoxic ischemic encephalopathy, the spectrum of the involvement of the brain can be very diffuse at times. At the same time, it could be significantly focal. So from a surgical perspective, usually we see large post-infarct porencephalic cysts. And if these cysts are limited to one hemisphere, then they are very, very good candidates for hemispheric epilepsy surgery. That is a hemispherotomy, and they have got excellent surgical outcome. In fact, the best surgical outcome in hemispherotomy has been described for porencephalic cysts. But at the same time, you could have a very focal gliosis. Sometimes you have got diffuse bilateral gliosis. So it is usually the diffuseness of the pathology which determines the final prognosis, both from a seizure outcome perspective and from a functional independent quality of life perspective. So if we have got focal resectable unihemispheric pathologies, definitely they may be candidates for a epilepsy surgery curative resection.
Can you please name the epilepsy surgery centers?
Yes, madam. I saw your question. I just put in an answer. So in the government sector in Kerala, we have Sri Chitra, and in the private sector, we have Amrita, both of which are well-equipped level 4 epilepsy surgery centers. So epilepsy surgery centers for pediatrics, at least, they are classified into level 1, 2, 3, and 4. So the level 4 centers are the ones which do the entire spectrum of epilepsy surgery, including invasive EEG monitoring. Level 3 centers are those which can do the basic resective epilepsy surgery procedures. So in Kerala, both Sri Chitra and Amrita are the epilepsy surgery centers. Outside Kerala, even for North Kerala patients, we have NIMHANS. We have got many other centers in the private sector in Hyderabad and in Bangalore, which do epilepsy surgery on a small scale, maybe not in a very high volume, but basic surgical procedures are done extremely well even by these centers. Then further in the country, we have AIMS, New Delhi, and some of the other peripheral new AIMS which are also taken up epilepsy surgery. But the epilepsy surgery program in AIMS New Delhi is also quite old, almost started about a year after Sri Chitra started.
Okay, George, here is a question from Dr. Sachin Baldava.
Yes, I saw that question. I was going to.
When and how do you decide to do corpus callosotomy in a patient with drop attack, and what are the preoperative workup needed?
Okay, but before I answer the question, Dr. Sachin Baldava is actually a very prolific neurosurgeon who practices in the city of Solapur. So you can imagine the impact that IMA Thrissur has made all over the country through this webinar. So Dr. Sachin Baldava is very versatile neurosurgeon who does a lot of epilepsy surgery, a lot of neurosurgical procedures, including epilepsy surgery in Solapur, and especially works among the economically backward neurosurgical patients there. So answering the question, corpus callosotomy is usually done with a palliative intent. So it's not a focal resective procedure. So these are usually done for patients who have seizures originating from both sides of the brain, and we don't have a focal resective focus. So primary generalized epilepsy is usually the pattern. We have an EEG pattern where the seizures originate from both sides, and the seizure semiology, which usually does well. Now you could have complex partial seizures, you could have had generalized tonic-clonic seizures, both with a generalized origin, that is from both the hemispheres. But the semiology wherein there is atonic seizures or drop attacks, where it is from both sides, both hemispheres, are usually the patients who do extremely well with a callosotomy. And the typical syndrome usually which does well is known as the Lennox-Gastaut syndrome, which is actually a primary generalized form of epilepsy. And I think Sachin also asks what in the preoperative workup, how do you decide? So the preoperative workup, usually patients who undergo a corpus callosotomy do not have any resectable focus. So they usually have bihemispheric atrophy, and very, very rarely would they have a focal lesion. Sometimes you may have some generalized white matter signal intensity changes or anything, but no focal resectable lesion. And the semiology wise, there is primary generalized epilepsy in the EEG, and the seizure semiology would probably be a atonic seizure or a drop attack. So there is also a message which says that Maitreya Hospital in Kozhikode also does epilepsy surgery. So there are a lot of I think government centers also which are taking up epilepsy surgery. I'm sorry if I have missed out any of them. I only talked about the epilepsy surgery programs. So there are, I think the key message here is that we have to refer to a specialized center with a neurology department which can initiate a pre-surgical workup. So that can be probably done almost in every all the government institutes in Kerala. And the basic epilepsy surgery procedures have been taken up almost by almost all the neurology, neurosurgery departments in the medical colleges in Kerala now.
I have one suggestion for the way forward. All the neurosurgeons and neurology team of Kerala, for the last few years, you are celebrating Epilepsy Day, International Epilepsy Day, but all those talks never stress on this aspect of the cure chance of this intractable epilepsies. The awareness among the peripheral general practitioners, pediatricians are less. They maybe what you said, the pharma influence is definitely there, and the sponsors are definitely there. The choice of the topics in many of these day celebrations are not, they're somewhat ignoring this part. I think we should be taking a move to create awareness among even the lowest level people who are actually taking care of this epilepsy part. Or why not we develop a registry for the epilepsy, irrespective of the age, pediatric and older age group? Maybe at the beginning of the starting of the epilepsy treatment, we are all giving care, but once after a few years, we are losing the follow-up. So can we do a registry? It's some sort of a software so that we can trace the really deserving group of the people. So that this benefit can be there at least in the coming years.
Thank you very much. Dr. Gilwas has gone silent. Over to Dr. Joy Manjula.
Professor Purushothaman has suggested a very good thing, but I don't know how we can make it practical. For that, we need the help of the eminent neurologist and neurosurgeon. I think Dr. Anandakeshavan can do something. Am I correct, Dr. Purushothaman?
So associations can do, but to what extent? Because a lot of other influences, as Dr. George pointed out.
There is one possibility, because if you look at the Scandinavian countries, there is a lot of monitoring of the medication use. For example, anti-epileptic drugs use, who is purchasing it, how are they using it? If somebody is using medicines for more than 2 years, or somebody is using 2 medicines, 3 medicines, they have it all in their records. It is not actually a disease-specific registry. It is an entire health record system of the country is computerized. So they have all this. Many of the research that come from Scandinavia are based on this kind of analysis. So filtering out those records, we can actually find out who are the children who are taking more than 2 medicines for more than 2 years. And then what is the situation? Like that, if you can do. Nevertheless, the choice whether someone should approach a doctor for treatment is also an individual choice. Whether they should, we cannot force anybody to, now you have 2 years, still you are still seizure not free, you have to come for a priest. That's also not possible. But we can definitely find out the spectrum of group or people who have these problems. Apparently, in our country too, we have a move towards developing a national health record system. And if that turns out to be reliably maintained, we may be able to get quite a lot of information on that. And Aadhaar or some sort of a linking will make sure that there is not much duplication in it.
Any more questions? So we will conclude the session because we had taken already more than 2 hours.
Yeah.
Okay.
I think I took a little longer time than actually I was allotted. I must say that.
No, it was very informative and we all enjoyed it. There is no harm in it. So, shall we conclude the session?
Yes, sir.
Okay. Dr. Haru?
Yes, of course.
And with your permission, I am inviting Dr. Baby Thomas, our treasurer, for the vote of thanks. Or to you, Dr. Baby Thomas.
Am I audible, sir?
Yes.
Yes. Respected IMA State Senior Vice President Dr. Gopi Kumar, Branch President and IMA State Joint Secretary Dr. Joy Manjina, our Branch Secretary Dr. Joseph George, and our scientific session speakers today, Dr. Sanjeev Thomas and Dr. George Galandanam, and the chairpersons, Dr. Harun M. Pillai, Dr. P.C. Gilbert, and all the guest members from other branches and senior members and all their IMA members. It is with great pleasure that I am here to express our gratitude to the audience in this online platform. First of all, I take this opportunity to thank Dr. Gopi Kumar, Dr. Joy Manjula, Dr. Joseph George for conducting this session. Next, I would like to extend our thanks to Dr. The scientific session speakers, Dr. Sanjeev B. Thomas, who has given us a collaborative class on epilepsy beyond seizures. So Dr. Sanjeev sir, we extend our heartfelt thanks to you on behalf of IMA Thrissur. Next, I would like to thank Dr. George C. Bilandalam, Professor of Neurosurgery, Sri Chitranandal Institute of Medical Science, Trivandrum, for taking a very informative and excellent class on the newer trends in the surgical aspects of epilepsy. Actually, most of the doctors are not aware of such an option, surgical option in this treatment of epilepsy. So, on behalf of IMA, I take this opportunity to thank you, sir, on behalf of IMA Thrissur branch. Thank you. Then I would like to thank all the senior members, the members from other branches, and also we are very happy to that one Dr. Sachin from outside Kerala also participated in this session. So we are very thankful to all of you for making this session it's a wonderful event. So once again, I thank you, all of you, and Jai Hind, Jai IMA.
Thank you. Also, the meeting is closed. Thank you all. Thank you. Good night.